It's 4 p.m. Italian time, so it's time to get started with Food for Veins, Veins for Food. As always, we welcome 30 seconds to allow everybody inside the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins, Veins for Food, a not-for-profit humanitarian and educational initiative that always starts with the art and heart of Monica Golovinsky, dedicated to all the health professionals who have shown such a good art during this tough COVID time, to which this humanitarian also project is dedicated in support in particular of the post-lockdown economic crisis as reported by this interesting paper on Lancet. Nothing would have been possible without a massive group effort of truly stellar faculty members and also of all the colleagues and friends who so nicely joined this group. And this is also the chance to deeply thank all the ones who joined us last Sunday. I take this chance to deeply thank Professor Chi and Dr. Cavezzi for their time during the week for answering to all the questions they received as keynote speakers last Sunday. And I remind you that also today you can make questions in whatever language inside the question and answer box. So not in the chat box, in the question and answer box, in whatever language. And during the week, the keynote speaker will reply to you. Today we focus on a very important topic, venous active drugs. As always, we deliver international CME. And we enjoy two outstanding speakers, Professor Fidor Luri and Professor Raffetto. We will introduce them later on properly. We also enjoy simultaneous translation in Chinese. So if you want to keep on listening in English, please do not touch any button. Simply enjoy the webinar. If you want to listen this in Chinese, you click on the interpretation button, you choose Chinese, and you mute the original audio. I take this chance to deeply thank Professor Urbanek and Professor Mansilla for having co-worked with me in delivering extra educational material you can find inside the platform dedicated to the topic of this module. And I deeply thank them once again for serving today as honorary chairs in delivering the take-home messages together with Professor Shen Ming and also Jin Song Wang. But not before having enjoyed the precious contribution of the continental top experts who will introduce one by one later on, we deeply thank for their precious participation. As we deeply thank all the individual donors and also the Magnificent Seven, as we nickname them, for the unbiased contribution to this initiative. So thank you, Emno, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. I deeply thank you all. I truly hope that we will be together soon for food moments dedicated not just to humanitarian and educational initiative, but also to celebration of our friendship that today we could dedicate to a very special person, Ted King, who is celebrating his birthday today. At this point, I always celebrate the colleagues and friends I consider also family. So I let Oscar and Willie to welcome all of you. Oscar.
Thank you, Sergio. Welcome, everybody. And thank you for attending a virtual Sunday meeting after a successful webinar on IVUS and thrombosis we had yesterday. Remember, you can make questions in English and in Spanish too. Por favor, pueden hacer sus preguntas en español que serán respondidas a la brevedad o durante el meeting. Muchas gracias.
Thank you so much, Oscar. Willie, with a particular thank you for being with us at 7 a.m.
Yes. Good morning, good afternoon, good evening, everyone, wherever you are. I don't know how many sessions we already have, but please enjoy the fascinating show from Dr. Lurie and Dr. Raffetto. 各位同道们，早安、午安、晚安。今天又是我们第8次的网上会议。如果你有任何问题，请在我们的答问箱里提问，我们尽快的回复您。谢谢。
Thank you so much, really, also for the special coordination with the Chinese colleagues and friends. As always, according to the format, we start with a guest of honor, and it's a particular pleasure for me to introduce a very special person in Italy and also in my profession and heart part, because he's really a special human being and professional in representation today of the National Federation of the Medical Board. Dr. Francesco Noce indeed represents in this case the multi-specialty teamwork that we need in venous and lymphatic ward. And here is his opening.
Dear all, being the guest of honor of a Food for Veins webinar is my true honor as representing the whole medical category is. Indeed, particularly in this difficult COVID time, all the medical categories must gather together to learn from each other, particularly on the large topics such as venous and lymphatic disease and the related thrombotic risk. If this mission is accomplished also by providing humanitarian support in hard post-lockdown economic time, then we really achieve what we saw during the Hippocratic Oath: help all the one is need. Once again, deeply thank you to all this incredible group of professionals for this remarkable initiative.
And I deeply thank once again Dr. Noce, because he has always been involved in coordinating different specialties together in many of our initiatives in the venous and lymphatic ward. So I hope he can set an example for multi-specialty involvement. Now we get to the scientific part, and as you know, we always try to keep also a social spirit, joking around the coupling of the big keynote speakers with big professional figures from all around the world. In this case, we have to repeat ourselves, because introducing Professor Fedor Lurie is like introducing Mozart, and indeed we got started with Food for Veins with him as a keynote speaker. We couldn't start bigger than this. Everybody knows him. He's head of the Jobst Vascular Institute, and he's also a leading figure of the American Venous Forum. We keep on saying that it's not just where you go, but also who you're traveling with. And since he's traveling in this life with Galina, and many of us know what a precious person Galina is, he's a very precious person as well, of course. So Fedor, the mic is now for you, for venous active drugs, and the question, do we really need them? Fedor?
Good morning, good afternoon. I should say hello because it's probably more time neutral. And I'm starting sharing my screen. See if you, right?
Perfect. It is sharing. Okay, so slideshow now, and then we are ready to go.
And we're ready to go. Perfect. Well, first of all, thank you for the opportunity to address that interesting question. So my task today is to give you the answer to this question. In other words, to define the need for inactive drugs, which means I don't have to show you the evidence of their efficacy or to compare which of the existing drug is more or less effective. I also don't need to describe how they work. Dr. Effetto is much better qualified to address this in the next lecture. So the only thing I need to do is to justify why we need the inactive drugs. Before I start, I also want to thank the sponsors who made this event possible. But since we're talking about drugs and medications, I really want to thank the people from medical industry. We realize that during the epidemic, they have disrupted supply chain supplies, increased cost of components. Nevertheless, they work tirelessly to maintain the supply of medication to our patients at pre-COVID cost, which is remarkable. I have no conflict of interest. However, I do share surgical bias. As surgeons and interventionalists, all we do is we just change an anatomy in order to correct the pathology and normalize physiology. And that is why the current view on etiology of chronic venous disease is a reflection of such bias. We assume that etiology or causes of the disease are either reflux or obstruction or combination of those, simply because we can correct those causes surgically. And you can see it here. So the question is whether those views on etiology are really true or not. So let's start with the natural history of the chronic venous disease. Epidemiological studies consistently show that reflux is absent in the majority of patients with chronic venous disease. And reflux in saphenous veins is present only in 1/3 of such patients. I'm presenting here just bone vein study, but you can look through all epidemiological studies with the same information. However, the symptoms and signs of the disease affect many patients who do not have neither reflux nor obstruction. We know that reflux in saphenous veins develop later in life than other manifestations of the chronic venous disease. It also progresses in the course of the disease. So the question is how frequently this reflux progression leads to the progression of the disease. Again, epidemiological data is strikingly consistent. 70% of all patients do not progress to more advanced stages. This progression, if it happens, has the same rate in patients with simple varicose veins and in those with chronic venous insufficiency or combination of those. The majority of patients with early stages of the disease do not develop any reflux later in life. Yet the rate of progression to more severe disease is not different from patients who had reflux in their early stages and those who did not. Ladies and gentlemen, the evidence is overwhelming that reflux is not the cause, but sequela of the disease. It is not the hemodynamic, but inflammation and neoangiogenesis that drives the disease progression. Those two processes are tightly connected, sharing the same pathway. Venous ablations, either surgical or endovascular, actually amplify the inflammatory response even further. They have the same rate of recurrences, but at the different locations. And those locations coincide with the places where the interventional trauma occurs. In this study, Sergio, you can comment later, the trauma was minimized in the group B. And you can see that the source of the recurrence was minimized only in the same area, but not in the areas of more distal perforating veins. It is clear that inflammation and neoangiogenesis are present in all disease stages, and they are amplified by venous interventions. Those processes are the major conditions that drive disease progression and to severity of the disease manifestation, as well as they contribute to incidence of the recurrences. Fortunately, these processes respond to medical therapy with veno-active drug. It has been shown for earlier stages of the disease and for the terminal stages of the disease. As a matter of fact, they are effective to a degree to all disease stages. They also can be beneficial after venous interventions. It is interesting that patients' preference is the medical therapy, and more compliant patients are more compliant with the medical therapy compared to other modalities, especially to compression therapy. It is especially important for the obese patients. This and other studies show that obese patients have worse compliance with the compression, yet their compliance with veno-active drug is remarkably high. In summary, my answer to the posted question is yes. We really need veno-active drugs to address more important pathological processes in chronic venous disease, to alleviate patients' symptoms and signs, and to prevent disease from progression and recurrences after intervention. And last but not least, because, I'm sorry, my slides is jumping, patients are more compliant with therapy compared with other therapeutic modalities. So my message to you, ladies and gentlemen, is that we should treat the disease not just manifestations such as reflux. To do so, we have only two options currently, and Veno-active drug is one of them. So thank you for your attention. I believe I tried my best to justify that we do need Veno-active drugs. Thank you very much once again.
Peter, thank you so much for such a brilliant answer to a so difficult question, and also thank you for quoting me. So now we start the World Scientific round, and we start with dear friend Chris Pittman from the American Venous Lymphatic Society. Chris?
Well, thank you, Sergio. Amazing meeting. Only you could put on something like this, and congratulations. Fedor, that was an awesome discussion, greatly appreciated, very, very interesting. And I had to think hard about this question. And my question for you, Fedor, is there is good evidence to support medical therapy to reduce vascular risk factors in patients with peripheral arterial disease, such as lipid lowering, blood pressure control, and antiplatelet agents. Thus, I do assume there will ultimately be some role for medical therapy in venous disease. However, unlike arterial disease, superficial venous disease occurs almost exclusively in the lower extremities, strongly suggesting a significant anatomic basis for the disease process. How do you resolve the exclusive anatomic location of superficial venous disease in the legs with arterial disease, which is a systemic disease process? Thank you.
Well, this is, Chris, this is a fantastic question. I wish I have a straightforward answer to that, but I do want to point out on one thing. I believe that it is a mistake to say that the chronic venous disease is only affected the lower extremities. It is a systemic disease the same way. We have pathological data that confirm that the changes in the venous wall are exactly the same in lower and upper extremities in patients with varicose veins. We also have data that show that the behavior of fibroblasts in the skin, surprisingly, is exactly the same when the samples were taken from the upper extremity and the neck as the patient samples that were taken from the areas around venous ulcers. So I think it is a mistake to say that the disease is located. It is a systemic disease. Now, manifestations of this disease mostly are prominent in the lower extremities, I believe, for pure hemodynamical reasons. But again, I think it is a systemic disease.
Thank you so much, Peter, and thank you so much, Chris. Now we fly all the way to Europe, and it will be the pleasure of Professor Bottini to introduce the Continental Top Expert representative.
Yes. Yes. Let me introduce Dr. Rodrigo Rial from Torrelodones University, Spain. Rodrigo, go ahead.
Hello, good afternoon, good morning, good evening to everyone. Thank you very much. I want to express my deep gratitude for the invitation and really honored. Thank you very much, Sergio. Thank you very much, Oscar. Congratulations, Professor Fedor. I want to ask you, most of vascular surgeons are aware of the last evidence about veno-active drugs, vascular surgeon and also phlebologists. However, many of primary care physicians who, by the way, who treat most patients with chronic venous disease are reluctant to prescribe veno-active drugs because maybe they lack the knowledge or other reasons. In your opinion, how could we bring this evidence to primary care physicians, general practitioners, and do outdated, erroneous topics? And what strategies, in addition to those that carry out by the industry very well, by the way, would you implement? What's your opinion about this?
That is just absolutely outstanding question. It is, I share your views, and I believe that this is the major issue, exactly as you say, the primary care physicians care for the majority of those patients, especially in the early stages. And I can tell you what's happening in the United States. It's absolutely outrageous. The medical doctors, people who graduate from the medical school, receive on average 0.06 hours of education about venous disease. So basically zero. They don't know anything about venous disease, how to treat it. During the postgraduate training, depends on the program what they are, they may or may not be exposed to that. Primary care physicians are well exposed to acute disease, the DVT, VT service, but absolutely, again, no or very little education on chronic venous disease. So this is the problem of education. To talk to professionals who are already practicing is too late. We really need to start with the medical school. We do several efforts locally, educate medical students, but it's very non-systematic. So my belief is that we all should address the core issue to educate medical students, include venous disease in sufficient time in the curricula for medical schools.
Thank you so much, Peter, and thank you so much, Rodrigo. Now we fly all the way to Kazakhstan, where I suggest you to go and visit both the Kazakhstan Venous Forum, that is a brilliant initiative, and also the country that is really beautiful. And the introduction will be from Professor Che. Willy?
Yeah, next we have one of the leaders of the Kazakhstan Venous Forum, Dr. Askat Sharapov.
Askat?
Askat?
Yourself?
Yes.
Oh,
Thank you, Sergio, and to all Wavin Foundation for inviting me to this great event. Thank you to Professor Luria for excellent and outstanding presentation. Thank you very much. My question is practical, and my question is, what can be main reason of recurrence after open vein surgery or endovenous procedures? Lack of adjuvant therapy with inactive drugs after procedures, or incorrect selection and practice of interventions?
Yeah, Dr. Sharipov, thank you for that question. I think my answer is neither one. I think the major cause of the recurrences is just progression of the disease, the natural history of the disease itself, wherever we do. My task was to justify that we need inactive drugs. Now, let me say something that is not very positive about inactive drugs. They're not really effective. They're effective to a degree, but it's not a game changer. We need another inactive drug that will really act on the pathogenesis of the disease. Then we may have a way to prevent more recurrences, because again, the majority of the recurrences is a progression of the disease. Some of them, of course, because of the surgical techniques and everything else, but that's not a majority.
And thank you so much, Askat and Fidor. Now it's my true pleasure to fly all the way to Latin America and Colombia to join one of the authors that was actually mentioned by Fidor and one of the biggest experts, Professor Jorge Ulloa from the Foro Venoso Latinoamericano. Jorge?
Thank you, Sergio.
Today is also dressed properly.
That's the VWin.
Yes, I know that you have also style today. Good.
And also I have this fancy mug, but since it's 9:23 in the morning here in Colombia, it's coffee inside.
Cool.
We can't say it.
That's evidence-based. You say Fidor is all evidence-based. So.
Okay, so here's the thing. I've read a couple of papers, very controversial papers, that says that perhaps some kind of particular venoactive drugs are conducting the way to reduce or decrease the CYP classification, turn the CYP classification into early stages. I'm finding it really hard to believe that that option can still be something that can be happening with the actual venoactive drugs. Do you think with the things that we have so far, we are going to see the day that perhaps we are going to treat those patients and even cure the patients with pharmacological purposes instead of surgical or any other mean?
Yeah, well, Jorge, when I was a medical student, I truly believed that by the end of my surgical career, I would not perform any surgeries because the medication will treat everything. Turns out not to be true, and probably another couple of generations who share those beliefs will still do surgery. I don't think we are really even close to understanding of the disease, so we can get those anecdotes right. Now, let me address another part of your question, which is very interesting. The changes in the C class. You know, it's I think it's everybody's observation that when you see young patients with dilated veins, even a few varicose veins, if you see them at two different points, you may see at sometimes those veins contracted almost disappear, not completely, but also, but that's in the young patients with the early stages of the disease. So that gives me a hope that during that stage, some treatment may actually prevent the progression to those. But when you see a patient with a, huge varicose veins and skin changes, in my experience, I never saw the reversal.
Thank you so much, Fedor and Jorge. And now we conclude in this way the World Scientific Round, and we deeply thank all the Continental top experts. And we move toward the audience, and we look at the ones who got more likes. So in the question and answer box, we can see that Silvia Guzman Rico was the one from Mexico getting more likes. I wonder where is, oh, there is also Wasila Ta, that is usually always positioning herself at the podium. And the question in Spanish is, let me translate this for you, Fedor, if I can. Is there any benefit in using venous active drugs before sclerotherapy? And in case, is there any preference?
This is a great question. I'm not aware of any publication that addressed that. So if you can do some study and publish that, that will be tremendously helpful. There are a few papers addressing the use of venous-active drug before and after interventions, both open surgical and endovascular, but not during the sclerotherapy.
May I ask you, Fedor, what would you consider to be a potential target of the action of this drug to be considered available? Because I think they are referring to preliminary investigation with pseudoxide and hyperpigmentation. So should this drug address iron release, control of inflammation, thrombotic risk, even if we demonstrated that the thrombotic risk with sclerotherapy is actually lower than other venous procedures? So what would be in your idea, if I can make a question, of a perfect drug associated with sclerotherapy? And
well, I think, Sergio, you're exactly right. I mean, those are targets. I don't believe that antithrombotic action is the major thing here in sclerotherapy, but I do think that inflammation, inflammation is such a broad term. And what we really need to have is the medication, the drug that acts on exactly that pathways that are initiated by sclerotherapy itself. Because then when you're talking about hyperpigmentation, reactions, it's all related to inflammatory response locally. So if we have something that acts on that particular mechanism, that's probably going to be the best target.
And then we fly all the way to Central America with Javier Cabeza from the group of Flebo-Latam, and he's asking you, he's saying, good morning, is the use of venous active drugs indicated in all stages of CF, C0, C6? I think we should also mention the fact that venous active drugs is a broad term. So maybe we should go down to some more specific drug, but question to you.
Right, and I think you and my other European colleagues and Chinese colleagues may be in a better position to address this question because they have more inactive drugs that we have in the United States. But based on the literature and our limited, again, this experience, the answer for the question itself is yes, they should be used in all stages of the disease. And the answer to the second part of this question, absolutely, there evidence that different venous-active drugs have different effects in different stages of the disease. Definitely Daflon 500 being demonstrated in the early stages of the disease, control symptoms and side, very effective. To a degree effective in the late stages of the disease, but not as much as in the early stages of the disease. And there were other drugs that were demonstrated in the later stage of disease. So the general answer is yes, they're different and they act differently in different stages.
Thank you so much. And now we fly all the way to Brazil, to Fabricio Jordan Santiago. Is there any, indeed, FDA venous active drugs approved in the US? Because we know that indeed that's made, also in UK, there was a paper quoting this issue of UK and USA not having that much.
Right, and that depends what you're gonna put in the label of venoactive drugs. So you know, for example, Trintal has a venoactive activity. It's approved in the United States. The situation in the United States is a little bit more complex because by FDA regulations, so FDA only regulate the therapeutic agent. So if there is a agent that contain several molecules of each of them had a different mechanism, FDA would not regulate that. This the reason, for example, why Daflon 500 cannot be approved in the United States, not because of it's not active or not, but just because of the nature of the same. However, similar or the same formulations are available as food supplements, which are not regulated by FDA. So we have similar formulation, not the same, available. Practitioners use that, patients use that. There are very little research and publications on use of those agents.
Thank you so much. And if I can use the opportunity of having you here, Fedor, indeed, say that I am a young practitioner and I want to get started with venous active drugs. As a science man, what would you suggest me to look at to consider among the spectrum of the different venous active drugs, the reliable, I don't want the name, I want, should they have like at least 2 randomized comparative trial? Should they have a safety profile of a certain type? Because we know the venous active drugs means a lot. But should I rely on something that has at least 1 or 2 randomized comparative trial, or is just best clinical practice? How you envision this?
Well, I think, Sergio, my answer to your question is threefold. I mean, one, obviously, if as a general practice rule, you should rely on something that has some reasonable degree of evidence. So, for example, Daflon 500, again, several randomized trials. You have to look critical on that, but you can use that based on this. Now, the second part is for if you have, as a practitioner, if you have an interest in the disease, you can use other medication, but in the research-like environment. So you have to really carefully design which patients you're going to give this drug and monitor their outcomes specific to what you're trying to achieve. Then, you know, in a year or two, you may have enough information to publish, and which will lead to some randomized trials and other evidence. So that's basically, and the third part of this question that I really want to do is, you know, in those situations when we really don't have a very nicely defined specific outcome, clinical observations, or even on individual patients, are extremely important. So if you see some remarkable effect on a patient or two, that should be a basis for your hypothesis that can be tested at some point. So share this view on the medical conferences with your colleagues. Invite more people so you can have more patients enrolled in those kind of studies.
Thank you so much. Brilliant answer, of course. Now, Hugo Navas is asking you if you agree on a lifelong venous active drugs treatment for CF1 and 2.
I do not. And the reason is not because I don't believe in the drugs, but you know, as I said, the majority of these patients, the absolute majority of these patients will stay the same. Their symptoms may be fluctuating, their signs, but for the many, many years, they will not progress. So to use the inactive drug lifelong on those patients doesn't make any sense to me, because it's basically, you cannot really detect the difference between just natural history of the disease or natural history of the disease that's treated with inactive drugs.
Okay, and now we get to the Cleopatra of phlebology, Wasil Attar. Great talk, Professor Lurie. In the past, venous active drugs reduces pain, bleeding, and hematomas after surgery. Does it still has a role post-intervention in modern recent procedures, which are like, of course, mini-invasive procedures?
Yeah, absolutely. I mean, there are quite a few publications that show the really positive effect of venoactive drug during and after surgery. But they are specific to specific complications, less hematomas, less skin discoloration. Again, it's exactly the same. It's a decreased inflammatory response to the surgical trauma or interventional trauma.
Fidor, I enjoy too much the fact of having you here, so I'd like to ask you another thing that I've always in my mind. BMI and these venous active drugs, meaning that we have always the same dosage and we usually don't add with that. Would you suggest us to explore also different dosages, or do you have the feeling that the mechanism of action is not influenced by the BMI?
Oh, I would definitely encourage to exploration of different dosages. I do not have the answer to that question right now,
sure,
as well as you. Right, so yeah, that's something that really needs to be addressed. As I mentioned, these patients, the interesting category, well, I didn't have time to go through the natural history. Natural history of venous disease in obese patients is different. And it's interesting that they are more compliant to the venoactive drugs. Several studies show that. So if the venoactive drugs are really working in this category of patients, that probably the issue is the dose, just to find the right dose.
Thank you so much again, Fidor. Luis Rocha from Brazil is congratulating you and is asking you about restriction for the use of venous active drugs. Do you use any of them in pregnancy or breastfeeding in patients with renal issues?
Again, I think I would rather ask the experts like Armando to talk about this, because we really don't have venoactive drug approved, and that limits the usage of those medications, especially in the categories of patients that you mentioned. So we do not use it in pregnant women or lactating women. For that reason, because this is not an approved, FDA approved medication. We don't really have good information about placental barrier and about crossing into the milk and so forth affecting the child.
Okay, and then we go with the last one. Dmitry Kazian is asking you, there is universal agreement to operate only symptomatic patients with varicose veins C2 or above. Should we operate if symptoms are well controlled with the venous active drugs?
I am not sure that there is a universal agreement on operating on C2 patients to begin with. Yeah, it's a common practice, I would say that, right? So here's the thing is, when we operate, when we do interventions, we disrupt the process that is caused by reflux. So we don't really act on the disease itself. We just slow down the disease progression. Now, if you're talking about earlier stages of the disease where the disease progression even slower than in C2 patients, then it becomes very questionable as whether we can or should intervene at all, unless there are cosmetic reasons or patient's preference. That's a different category, but not for the medical.
And okay, and now it's time to conclude this part. I think we used too much the privilege of having you here, but we couldn't help but appreciating that. So once again, deeply thank you. There is a virtual applause coming from hundreds of people who are live with us in this moment. So thank you once again, Fidor. And now we move forward. And if we introduced Mozart before, considering also the Italian origin of Professor Raffetto, we will pair him with Giuseppe Verdi, the great composer. Professor Raffetto, of course, needs an introduction, Harvard University and other leaders of the American Venous Forum, and more than anything else, is truly a friend of all of us. I don't know anybody talking badly about him. So it's evidence-based, he's a wonderful person. We'll talk about venous active drugs, future directions from the lab to the clinic. I know that Joe should be with us in this moment. Isn't it true, Joe? Are you with us?
I am with you.
That's fantastic. I know that you have issues with the internet connection, but we always have a plan B. So we will play your video, and then after that, the audience and the Continental experts will have the chance to talk with you, okay? So we go safely. Oh, okay, let's go.
Good afternoon. My name is Joseph Raffetto, coming to you from Boston, Massachusetts. I'm truly honored to provide this lecture on venous active drugs, future directions, and studies from our laboratory and other laboratories, and how we may apply what we've learned to our clinical application. I congratulate Professor Sergio Genesini on a wonderful meeting, the Food for Veins, and for all the attendees listening in. Look forward to our discussion later. I have nothing to disclose and no conflicts of interest. There are a number of venotonics. One of them is diosmin. This is known to decrease inflammatory response, increase lymph drainage. This is the structure you can see on the side there. It also increases calcium sensitivity for contraction. And it inhibits the catechol-O-methyltransferase, which reduces the metabolism of norepinephrine. This allows for the norepinephrine to be prolonged and increases vasoconstrictor effects and venous tone. The micronized purified flavonoid fractions are known to be edema protecting. They decrease inflammation as well as the leukocyte endothelial interactions. They inhibit the activation of leukocyte on endothelial cells, and they do this by inhibiting the ICAMs, VCAMs, as well as the selectins, and then potentiate norepinephrine contraction. Eshin is another venotonic, and it's known to increase endothelial cell permeability to calcium, sometimes called iron pore former. It induces endothelial nitric oxide synthesis by making the endothelial cells more permeable to calcium, and calcium ion is known to increase nitric oxide synthase, increase in nitric oxide. It is also known to cause release of vasoconstrictor, specifically the prostaglandin F2 alpha, which is a potent vasoconstrictor. It has sensitization of the vein wall to contractile effects of serotonin and histamine, as well as what we've studied, and I'll show you the data on this, is that it has calcium-dependent vein contraction. However, Eshin also disrupts a number of important other physiologic vasoconstrictors, such as the alpha-adrenergics, the angiotensin 1 receptor mediated, as well as depolarizing pathways. This is the structure for Eshin. This is a study that looked at both Eshin and diosmin. We know that these are utilized in treatment of varicose veins and pain and edema, but also used with more advanced forms of chronic venous disorders. However, the venous active properties of these two important venoactive drugs are poorly understood. It is also known that calcium is a major regulator for smooth muscle contraction. So we tested the hypothesis that Eshin and diosmin promote calcium-dependent venous contraction. This is the setup and model that we use. This is a bath that is filled with Krebs solution, physiologic solution. It is kept at 37 degrees Celsius. We bubble in oxygen. The tissue is about 1.5 to 3 millimeters wide, and it is stabilized and hung between two tungsten hooks to a string that is connected to a gas force displacement transducer. This is important because it measures the contraction and relaxation that then is displayed out on the polygraph. And then this is a magnified view of the chamber demonstrating where the tissue is placed. And it holds about 50 milliliters of fluid. This is a contraction and demonstrating both the intracellular and extracellular calcium dependence. On the left panel of A, C, and E is Eshin, and on the right panel is B, D, and F. In normal Krebs, which contains 2.5 millimolar of calcium chloride, increasing concentration of Eshin, 10 to minus 9 to 10 to minus 4, starts increasing the contraction of the tissue. If you add daltiazem, there's no decrease in the contraction. This is a calcium channel blocker. Normal Krebs with diosmin causes a very significantly decreased contraction that is measurable, but much significantly decreased compared to Eshin. Of importance, when you actually wash Eschen, the contractile tissue with Krebs, you see a relaxation, which is important because that means that this is not a state that is in rigor, but actually that it has other mechanisms, likely intracellular and downstream mechanisms. If we remove all of the calcium with EGTA, which binds the calcium ion, we see that this is a measure of intracellular calcium release from the SER. And what we find is, although it doesn't seem, but there's actually a measurable small amount of contraction. It's about 3.8 milligrams per milligram of tissue with Eschen, and it's about 4.2 milligrams per milligram for diosmin. This is a measure of intracellular calcium release, indicating that possibly there's other downstream mechanisms. And with the extracellular calcium, how it's measured in terms of the dependence for Eschen is where this has to come from the extracellular component. And here we add calcium chloride to Eschen and 0 calcium Krebs. And we see that there's an increase in calcium contraction with increasing concentrations. There's a significant decrease actually with diosmin and just a small measurable amount that's about 11.7 millimeters. 11.7 milligram per milligram of contraction, but significantly decreased compared to. This is the aggregate data demonstrating Eschen and diosmin, demonstrating the addition of Eschen and the contraction, and very significantly decreased with diosmin. And extracellular events, when you add increasing concentration of calcium with Eschen, you see a robust contraction versus control, whereas with diosmin, you do not see that. Importantly, though, the effects of Eschen and diosmin on other venous agonists, specifically the phenylephrine, which affects the alpha-adrenergic, the angiotensin, which is through the angiotensin 1 receptor, and potassium chloride, which is through calcium voltage-gated channels. We see that controlled is a robust contraction in all of these, but when you add Eschen, there's a significant decrease in the contraction of these important venous agonists. This may have significant effects and importance in clinical applications, especially for the duration and the length of treatment, because longer exposure may actually decrease the effects of other venous agonists, and this may be something that we have to contemplate on the duration of utilization of this drug. Diosmin, on the other hand, has no effect in terms of like increasing or decreasing the effects of venous agonists as shown on this graph. Importantly, though, diosmin does have calcium sensitization between the effective dose of 24 to 51 millimolar of potassium chloride. So this means that it does enhance the calcium mobilization through channels when you use potassium chloride. However, diosmin does not potentiate the effects of Eschen, as demonstrated in the lower graph, where Eschen shows the robust contraction with increased concentrations. However, when you add diosmin, there's no potentiating effect. So in summary, Eschen and diosmin, Eschen has significant calcium-dependent contraction. It does have some intracellular calcium release, which indicates that there's probably downstream effects. This is not a rigor state or ATP loss. Calcium channel blocker does not affect contraction. We only studied the L type. There's other types like N types that need to be studied. It does decrease the effects of vasoconstrictors, the alpha-adrenergic, the AT1 receptor, and membrane depolarization, which potentially has consequences on how long and the duration that we want to utilize this clinically. Diosmin, on the other hand, has minimal calcium-dependent contraction. It does have intracellular calcium release, likely affecting then some downstream effects, such as the MAP kinases or Rho kinases. Has no effect on vasoconstrictors, and there's no synergy of Eschen contraction, and it does have some increases in calcium sensitization at low depolarizing concentrations. So the next slide is another important drug that's utilized. This is a glycosaminoglycan. These are disaccharide units that are polysaccharides, highly sulfated. Solodexide specifically in panel A is heparin sulfate, which is about 80%. This is glucuronic acid and glucosamine. And in panel B, that's dermatan sulfate, which is iduronic acid and galactosamine. And this is the structure of solodexide. It has significant biologic effects, antithrombotic, anti-inflammatory, and endothelioprotective. And these are important properties of this drug that have been already studied and published. Although solodexide, and this was our question, has antithrombotic, profibrinolytic, anti-inflammatory, endothelioprotective properties with reported benefits in patients with chronic venous diseases, especially with patients with venous-like ulcers in clinical studies, and other thrombotic and atherosclerotic vascular disorders, the effects of solodexide on vein function and venous stretch are really not well understood or even defined or have been studied properly. So our hypothesis was that solodexide would inhibit metalloproteases in veins and enhance venous contraction under elevated tension and restoring venous function. This was a paper that we published before to show the relationship of venous tension, metalloprotease expression, and physiologic contraction of veins. We use 0.5 grams as our basal tension, which equates to about 21 millimeters, and the high stretch is 2 grams, which equates to 83 millimeters of mercury. These were the study objectives. This is a recently published paper on these observations with solodexide. So we wanted to determine if solodexide affects venous function, determine if solodexide can restore venous function, contractility at high stretch, and determine if solodexide inhibits metalloprotease expression and proteolytic activity in venous movements. This is what solodexide does with submaximal concentration of contraction with phenylephrine. It causes contraction with increasing concentrations versus the vehicle in B panel, which is a control, does not. This shows the aggregate data of solodexide contraction, and we measured in different means in displaying the data, both as the maximum contraction in milligrams, which shows the contraction, but when you adjust for tissue weight with milligram per milligram, we still get the same effect that solodexide increases the contraction with increasing doses and concentration of solodexide. Also, when you look at it from the percent initial phenylephrine contraction, again, there's an increase in solodexide versus the control, as well as when you look at it from the percent of 96 millimolar maximum contraction. So no matter how you look at the data, solodexide causes venous contraction versus control. Importantly, though, when you look at potassium chloride contraction, the control is robust. When you stretch the tissues to 2 grams, it decreases. But when you add solodexide, it actually restores the contraction. Actually, it's actually greater than the control. This indicates is that solodexide, in part, works through calcium mobilization and enhancing the effects through those calcium voltage-gated channels, which is how potassium chloride works when it contracts tissue. We looked at phenylephrine and the stretch model with solodexide. We see, importantly, from these graphs, and the message here is that solodexide causes a left shift of the phenylephrine contraction curve, which is important because what that means is that solodexide is increasing the sensitivity of phenylephrine to the tissues and to the receptor. It's not actually increasing the receptors, but it's actually the sensitivity of the receptor that's being enhanced by solodexide. This shows the effective dose at 50%, and this is a negative log, which the higher the number means the lower the concentration. And what we see here is that there's a significant left shift with the solodexide. Importantly, how does this happen? Well, one of the things is that solodexide, when we measure the metalloproteases, specifically the gelatinases, metalloprotease 2 and 9, is that with stretch, you get a significant increase. We've previously published this, but with solodexide, you get a significant decrease in the protein, both the proenzyme and the active protein for both MMP2 and 9 in the stretch model. So solodexide is protective. It inhibits metalloproteases. Well, we also wanted to look at the activity of the metalloproteases. And again, what we see is that with stretch, there's a significant increase in the activity of both MMP9 and MMP2. But when you add Solidexide in the stretch model, there's a significant decrease in the activity of these gelatinases. Extremely important because we know that metalloprotease 2 and 9 cause venous relaxation. So summary of Solidexide is that it restores venous contraction and inhibits metalloprotease expression and activity in enhancing venous contraction. Solidexide effect on venous contraction is partly by enhancing the sensitivity of adrenergic receptor. Solidexide could also improve vein contraction by enhancing downstream mechanisms such as calcium mobilization, affecting the protein kinase C, the MAP kinases, and the Rho kinases. And Solidexide may not just be important for venous leg ulcers as has been studied in clinical practice and our randomized controlled trials, but it may also be important in varicose veins and edema, as well as skin changes such as C2 to C5. Future directions is to determine if the effects are similar or different in females and males, because the data that I showed you from our experiments are all in male rats. We want to also evaluate the mechanisms in human venous system, both normal veins as well as varicose veins, to see if we have a similar effect of these tissues with contraction with these venotonic agents. We want to determine if other mechanisms of venous active drugs exist, such as the downstream pathways, such as kinases, calcium mobilization, ATP, mitochondrial function, and autophagy. Determine also if non-invasive means and biomarkers of detecting venous active function by these drugs can be used, such as utilization of high-resolution ultrasonography, elastography, or measuring cytokines and chemokines. Also want to determine what the optimal duration of these venous active drugs is, since from some of the studies with Eschen is that it decreases the contraction of other venotonic or other contractile agents and agonists such as phenylephrine, angiotensin, and potassium chloride. And certainly, finally, randomized controlled trials are required to clearly define patient-reported outcomes and also have long-term follow-up. I thank you for your attention. I look forward to our discussion and question and answer period.
Thank you so much, Joey. I hope you could hear all the people clapping. We are a lot. Now we will start with the World Scientific round. So we will start actually from Italy with Professor Agus from the Milan University, one of the biggest experts on the field here in Italy. Unfortunately, he's having some technical issues, so I have his question here. Joe, can you hear me?
Yeah, I'm going to turn it off just a little bit because, yeah. Go ahead.
That is great. So the question of Professor Agus, who has wide experience on the field, is about best clinical practice versus evidence-based medicine in the use of venous active drugs. So basically he's saying, considering the vast use we have had all around the world, and in particular in the European countries, and in particular Italy, should we rely more on the best clinical practice compared to the evidence-based medicine?
Yeah, of course. Obviously, when we have strong evidence, like good randomized control trials, will clearly define endpoints, and I think Federer Lurie really covered this well. That's where we can really apply the grade 1A recommendations. Of course, much of the data that we have is much weaker than that, as we know, and it's hard to apply all of these drugs that are venotonics with the current data to every single patient that comes to your clinic. I agree with Dr. Lurie, what he said about the inflammatory response, that's one of the mechanisms clearly that is going to be a critical component in reducing the symptoms. But without better data, it's not something that can be routinely prescribed, because we really don't even know, for as one example, is the duration. And I think that's a major factor. Do you actually stop antihypertensive drugs in a patient that has hypertension at a certain point? You don't. They continue for life. So we know that chronic venous disease is sort of a lifelong problem. So do you continue these drugs for life? And we don't have any data that I know of that has shown that these individuals, these patients who are on trials, are actually persistently staying on these drugs. So I have to say that we need better data.
Thank you so much, Joey. Now we fly all the way to Hungary, and it will be Professor Bottini introducing the Continental Top Expert representative. Oscar?
Thank you. It's my pleasure to introduce Dr. Imre Bihari, head of the Hungarian Venous Forum, who will be head of the EBF in Budapest next year. Doctor, whenever you are ready.
Imre, are you with us?
Thank you.
Imre, unmute yourself.
Can you hear me?
Yes.
Yeah, okay. So thank you, Sergio, very much for inviting me in this wonderful webinar. And this talk was very high level. Thank you very much. I have the following question regarding the future directions of venoactive drugs. I wonder if a venoactive drug would be beneficial in the treatment of COVID-19 infection. I mean to protect endothelial lining, thromboembolism, and against cytokines. What is your opinion?
I think that's a really great question. I was in New York City working for 2 months with COVID patients in the ICUs, and certainly you see a lot of endothelial dysfunction, just knowing from the fact that these patients are full of edema and they're on a lot of pressors to maintain their blood pressure. So I can't really disclose too much because it's sort of under embargo, but I know that there are some trials going on that are looking at some of the venotonics in patients with COVID in the early stages. I think with COVID, we have to be careful with the data that we're actually gathering, because having experienced this in New York City at the major hospitals for a little over 2 months, it's very hard to tease out what actually works and what doesn't. And I think another thing is the timing of when you deliver these drugs is very critical. But I agree with you that the endothelium is a very important part of the disease pathophysiology. The activation of adhesion molecules and the coagulation cascade, we believe that those factors are important in the microthrombosis and the microcirculation, getting thrombosis, as well as DVT, because I saw a fair amount of that, and end organ damage. So I think it has two components, both the arterial and the venous, and certainly trials will be really critical to see if these venotonics have any benefit in patients with COVID. But I think we have to be cautious. We need really good endpoints, good trial, and we have to define the population. Thank you for that great question.
Thank you so much. And now we fly all the way to San Salvador for our dear friend and a great expert on the topic. And it will be Professor Chi introducing him. Willie?
Yeah, next we have a good friend to VWin, who is a leading figure of the Pan American Society of Phobology, Luis Rodriguez. Luis?
Thank you, Willie, Sergio, Oscar, for the invitation to participate in this webinar. Of great interest, and especially for Latin America, where the use of venoactive drugs have high level of prescriptions as an adjunct of treatment of the venous chronic disease. Dr. Raffetto is always an excellent basic science presentation, always.
Thank you.
The question is in relation to the mechanisms of action of the venoconstriction or venous stones by sensitization or stimulation of calcium channel with positive effect on receptor alpha-1 and alpha-2 that you're talking about. You consider it's necessary to divide the venoactive drugs from the least to greatest venoconstrictor effect and include them in a prescription guide for patients with chronic venous disease and arterial hypertension or angina pectoris, for example, especially treated with calcium channel blockers, such as verapamil, amlodipino, nifedipino, for example.
So I just want to make sure I understand the question, because there's a little bit of breakup. So what you're saying is asking me, with these venotonics, the mechanism through calcium and how people taking calcium channel blockers may affect the venotonics?
Yes.
Yeah, I mean, so
the mechanism.
Yeah, and I think that's an interesting question, because there's at least 3 types of calcium channels. I studied one, the L type, but there's others too, the N and the M type. And we use the daltiazem, but of course, as you know, there's nifedipine. cardipine. There's a number of other calcium channel blockers. What we found, at least with Eshen, is that there was no effect by treating the L channel and blocking it at maximal concentration, reducing the effect. Now, it doesn't mean that other calcium channel blockers do not have an effect. And I think that's a really good point because, again, you know, when we look at individuals and we want to prescribe a drug or a medication, we have to also see what other drugs and medications those patients are on. Fortunately, at least in the United States, calcium channel blockers are not the first line of treatment for antihypertensives, but certainly mechanistically, they could have a potential effect on the venotonic. Because calcium is so important with venous tone and contractile mechanisms. So that's a really, really interesting question. We need to study that, obviously, because it would be interesting to see if patients who are on calcium channel blockers, regardless of the venotonic, have a significant reduction in the overall positive outcome of these venotonics, including pain, edema, and the progression of disease. Thank you for that question.
Now you have a research project for the next time you will go surfing in Central America. And Flebolartan will be a good chance for doing that. So we now move on the way to a little bit of Russia, a little bit of US, because Maxim Shaidakov is the perfect example of venous disease, meaning that is a combination of genetic factors and of environmental factors, meaning that the genetics are extremely good as a son of Eugene, but he is also environmental, meaning that he worked really hard and he is really doing extremely well, so much that he's now chair of the American Venous Forum Research Committee. So Maxim from US now, your question.
Hi, everyone. Thank you, Sergio, for this kind introduction and invitation. And thank you, Dr. Feto, for such a comprehensive but not too complicated review on an actual and sophisticated matter. It's clear that conservative treatment plays an important role in complex management of venous disease, and constant translation from basic science to clinical practice and back again is critical for clear understanding of what we do and why. Here is my question. A substantial number of patients with venous disease have chronic pain, or some sort of pain equivalence, if you will. Pain has always been one of the principal targets of pharmacotherapy. And quite intriguing, there is a weak correlation between CYP class and symptoms, and pain is quite common in patients with C0, C1, and C2 disease. Based on your large experience and everything you know in VEN-active drugs, what do you think might be the mechanism of action of these medications to alleviate pain in patients with C0, C1, C2 disease when chronic inflammatory skin changes and edema are absent or at least not measurable at this point?
Thank you, Dr. Shaidakov, for that really interesting question. And I apologize, I wasn't looking at the screen, but I was getting my iPad. This is how I'm keeping the hotspot. This is how I'm keeping alive this whole system, because I told Sergio I had some issues. So I had to reactivate it before I lost everybody. But, you know, that's a really interesting question because we know that it's complex. We know that. And one of the things that's important is that vein stretch. So we're just talking of the C1, C2. And you know, really, I think what happens is it starts with changes in the endothelium through shear stress and the glycocalyx. That's a critical component. We need more information on that. But we know that vein stretch, and I showed you a little bit of data when we did the silodexide experiments. The vein stretch causes metalloproteases to be expressed, both the active form, the pro form, but also the activity is significantly increased. And the metalloproteases are known to carry out other functions and induce other cytokines as well as other metalloproteases. And so if you think about it, is that with that stretch, you might have matrix metalloproteinase 2, 9, maybe even the 3 and the 7s, or even metalloelastase, which is 13. They can cause inflammation through other pathways. That's one possibility. We also know from data from Takase and Ono, from John Bergen's lab and Schmidt-Schombain's lab, where they actually demonstrated in patients both. They had it was C2, 3, and 6. So this is a combination of different veins that they were looking at. They looked at great saphenous vein, but there's certainly monocytes, and you have macrophages that enter the tissues, and these are well known to be causing inflammatory responses. So you should not see any leukocytes within the tissue wall. And I think that that effect with the metalloproteases, monocytes getting activated and going to the macrophage stage and going into the interstitium as well as the venous wall affects those receptors, those fibers that are pain sensors, like the C fibers, and eventually that inflammation relates to pain. And certainly you don't even have to have thrombophlebitis. We know that causes pain, but you don't have to have thrombophlebitis to have pain in these individuals. I think the complexity is like which cytokine, which metalloprotease, which target do we want to target? And I think these venotonics, as we demonstrated, at least with Solodexide, we have not demonstrated with Eschen and Diosmin, but at least Solodexide reduces this expression and activity of metalloproteases. So we think that that's possibly one mechanism. Through other work, through Ferdinando Manello, he's shown that actually you can decrease the monocyte macrophage expression of a lot of different cytokines, including the interferons, the interleukins, the MCPs, the MIPs. So it's a very complex process, a very intriguing question. And I think as I showed in the first couple of slides with Eschen, Diosmin, and MPFF, is that they definitely have these immune modulating effects. If you look at the Diosmin and MPFFs, they really immune modulate, they reduce the interactions between the endothelium, the monocyte on the endothelial surface by those adhesion molecules, and the Eschens are more like with the contraction component. But certainly a lot more to learn. I appreciate that question, and I know it's kind of a long answer, but I get excited when I start talking about these things.
Thank you so much, Joey. It's an applause from more than 1,000 people from all around the world, and you really deserve that, not just for the science you brought in, but also for the wonderful clinical work you have done, both in the research and also on site, because once again, it has been wonderful what you have done as a volunteer in New York during this
Thank you, Sergio.
time. So thank you so much for being here, despite the difficulty of the connection. Do you still have 5 minutes?
I do. I still got this is still working.
Okay.
So we still have connection.
So
yes.
Fabricio Jordan Santiago will be happy of this because he's the one who got more likes in the question and answer box. And he's asking you this, Joey. Beyond anti-inflammatory effect of venous active drugs, do you think that we also have hemodynamic improvement? And what should be the best tool to demonstrate it? Quantitative, qualitative, or both?
Yeah, very difficult question to answer with minimal data, because a lot of the studies that are actually looking at the venotonics, the venoactive drugs, and of course they have a lot of different names, but they're all the same meaning. You know, a lot of them you're looking for symptom relief, and you're not really measuring whether, and what is our surrogate measure? It's going to be what? Reflux. But what's interesting, obviously, what Federer showed is that reflux, really, a lot of these people don't have it, and yet they have the symptoms. So that's why we target the symptoms more so than the actual hemodynamics. And I think probably we don't have enough of a resolution to start looking at some of the things that are changing within the vein wall. But one of the things that I put there at the end was that actually elastography might be one of the things that we want to look at, which can be measured. And that's when you look at that, it's this vein wall stiffness, and that can be measured. And one of the things is that the vein wall may be the same diameter, but yet the patient has symptoms. But then if you measure the elastography of that, what may happen is that it may change and become more compliant. And if that correlates with the symptoms, you may have an indirect, non-invasive way to measure something that's significant, that's changed in the vein wall, as opposed to just looking at reflux or other, what else do we look for really when we look at hemodynamics? We can do air plethysmography, but not many people are going to measure that in patients with venotonic agents. So very, very difficult to know for sure, but I think symptoms are the better way to actually measure. They probably do have some hemodynamic effects, but symptoms is a much more sensitive, I think, in pain value, outcome value.
Last quick question from Ricardo Rodriguez. Do you agree to the use of combination of venous active drugs?
I think there's a few studies out there that showed some benefits. I don't remember all of them. I think that, again, we have to be careful. There's side effects with these drugs. We all obviously have to keep in mind, I always keep in mind a number of things when I start looking at Venotonics. And unfortunately, in the United States, we only have one, Release Vascular, which is a diosmin-based drug. But what's important is, number one, is do you have an indication? Two, you have to think about the side effects. And the other thing is the cost, and we forget about that. But also, you have to think about how many individuals do you have to treat to really have the positive outcome. If we have to treat 300 to 400 individuals to get one positive outcome, it's not going to be worth the cost analysis. It's just not cost effective to do that. And that's why, again, we need, even Federer mentioned this, and I mentioned it too, we really need critical studies, and also the paper that you published from our scientific meeting that we had in Cortina, Italy, with these venotonic agents, is that randomized control trials with really clearly defined endpoints are absolutely necessary so that we know which drugs work and which ones do not for the specific condition that we're trying to treat. So I personally do not use combination drugs. I think you're just adding a lot of things without much evidence for it, and I would caution people from doing that.
Joey, in Italy, your Italy is 5:15, so we are perfectly on time to say thank you so much for having done this despite all the difficulties and connection. I know it's a tough working day, so if you want to stay with us until the end, it's like the last 15 minutes. If you have to go, deeply thank from all of us for the wonderful.
I haven't gotten I'm on call. I have not gotten paged. I'm covering the hospital, so I'll stay on.
But we made it, and thank you so much again to you and Fedor. Now it's time to move to our giants. It's my true pleasure to get into the honorary chair session, where we have big figures of our venous and lymphatic ward telling us what the take-home messages are after this webinar. And it's my true pleasure to introduce Professor Armando Marcila from the University of Porto, editor-in-chief of the International Angiology Journal. Armando?
Thank you. Good afternoon, everyone. Thank you, Sergio. Congratulations for this huge organization. You deserve all our gratitude for this project. Also, my compliments to the organizing committee, to Oscar and to Willie, to the outstanding speakers of this afternoon, my good friends, Dr. Fedor Lurie and Dr. Joe Raffetto, and also to the Continental top experts representatives. And a special compliment to the participants, almost 600 participants in Sunday afternoon, at least here in Europe on July. This is amazing. So again, Sergio, congratulations for this. Concerning this webinar and in my view, the highlights of the presentations and the questions and answers, I would say that we all know that chronic venous disease is a progressive disease. It is more than predictable that in the next few years, the prevalence will rise due to the aging population and also the epidemic obesity on the Western world. The venous symptoms are, by us clinicians around the world, underestimated, undertreated. They have a significant impact on quality of life, and we can quantify that using the questionnaires to assess that. And if you read the latest guidelines on venoactive drugs, at least from Latin American Venous Forum on 2016 and European Venous Forum on 2018, it is possible to analyze the evidence produced for the different venoactive drugs, because the evidence is not the same for all of them, because the mechanism of action is not all the same for all of them. And we can have evidence with different levels of evidence, but evidence to reduce the leg edema, to improve the different venous symptoms. And I would like to emphasize the new approach by IVF last year with the assessment of each specific symptom and the relationship with each specific venoactive drugs, and obtaining a number needed to treat for one positive result. What is important, as Joe mentioned, concerning cost efficacy. So we have evidence for this, for symptoms, we have evidence for leg edema, we have evidence also as with the use of venoactive drugs as an adjunctive for the venous ulcer healing. What we don't have, or at least the evidence is less robust, is concerning the progression of the disease. We cannot say with robust evidence that venoactive drugs can stop or avoid the progression of the disease. We cannot say that we have evidence concerning the recurrence of varicose veins. We don't have robust evidence concerning the recurrence of ulcer healing. We don't know if the different venoactive drugs have the same effect on symptoms related with primary chronic venous disease, or if the severity of the symptoms are different on post-thrombotic symptoms, if the effect is or not the same. We also don't know, or at least the evidence is less robust concerning the use of venoactive drugs together with the different surgical interventions, more or less invasive, or even as adjunctive for foam sclerotherapy. So, in my view, we have a lot of research fields yet to explore, and we need well-conducted randomized controlled trials to answer to all these questions. These were my comments, Sergio, the highlights of these two outstanding presentations. And again, thank you to you, and thank you to all the speakers in this afternoon. Thank you.
And it's me deeply thanking you, Armando, also because it's a tough day. So your commitment in being here is really appreciated. And indeed, I'm also impressed because I was preparing when you told me that maybe today you weren't able to join us. Some take-home messages also from my side. And I was actually brainstorming in the same more or less direction of yours, with known knowns, known unknowns, unknown unknowns. So if I can say my point of view in this is that we have seen that we have to discriminate between the different venous active drugs rather than considering them together. So we have seen that MPFF has been validated with a high grade of recommendation, but we have also seen in the work we have done together, and this is a chance to deeply thank all the ones who have been involved with the Winter 2019 Global Guidelines document, that we should make these guidelines more homogeneous around the world. We have seen that suloperoxide has validation in thromboprophylaxis aspect that, particularly in this COVID time, could be of particular interest, and the recent publication of Carol has extended its indication through all the CVD spectrum also for the inflammatory part. But we have also known unknowns, I think. For example, we know that we have a smaller compliance toward compression, but we also know from many years ago with the Raju 2007 already showing us that this compliance is actually our fault for the compression part, because up to 60% of cases and even more are not tolerated because of wrong prescription. So we should work better on that. You know that I'm really passionate about the topic of fake news. So I really want to have this slide also not to propel fake news in venous active drugs as in compression. I think it is our duty as societies and scientists to avoid confusion with patients and health professionals on what is validated compared to what is not validated, both in compression and in venous active drugs. And at the end, unknown unknowns. So the things we don't even know that we don't know. So the important part that also Fedor and Joe pointed out, of moving from macro to micro aspects, from the physics and hemodynamics to the biochemical aspects. A thing I'm always wondering is also the bias of the psychological component in venous active drugs use that has been quoted in these two papers you see reported over here with the Journal of Clinical Nurses 2019 and the one of 2018. So this was my brief comment, and it was actually in line, I would say, with the one of Armando. And again, this is to deeply thank once again Armando for the commitment also in this particular day. So thank you so much once again. At this point, we move to another giant, that is Professor Urbanek from Silesia University. We all know him from the wonderful UIP meeting in Krakow and for the many achievements he has shown us. So Thomas, the mic is now yours for the take-home messages.
Good afternoon, everybody. As we saw, many questions should be answered in clinical and also in laboratory level. And I think, as Armando already mentioned, we should use rather individual approach to the patient, to the clinical situation, to the symptoms. We know that the symptoms of chronic venous disease are not much specific, and that's why for sure we need to hear the patient. We know that in many cases there is a very poor correlation between the symptoms and signs, which is very important from the clinical point of view. And we should probably not try to evaluate the global effect of the venoactive drugs, because no doubts for me that we need these drugs. We need these drugs in our daily practice, but we should probably not evaluate the global effect. We should focus on the particular drug in terms of the efficacy on the particular symptoms. And this individual approach was proposed in the recent EVF guideline document. Joe Raffetto mentioned about various activities and various ways of acting of different venoactive drugs. And this corresponds to the clinical approach, because there are some drugs that are more efficient for swelling. There are some drugs which are more efficient for pain than the other drugs regarding the evidence that we have. But of course, this evidence in many areas is not sufficient. And I know that this is wishful thinking, but we should wait for and look for the study that will document any efficacy from the clinical point of view of the venoactive drug on the disease progression. However, I don't know if our life will be not too short to see the results of this study. But congratulations once again, and thank you for the invitation. Thank you very much.
Thank you so much to you, Thomas, for all you do and you have done. Difficulties are opportunities, meaning that Professor Shenming Wang had connection issues for which he sent us a video, but the opportunity will be that after him, we will also enjoy Professor Jinsong Wang, who is joining us for the take-home messages. So here is the message from Professor Shenming Wang.
Dear Professor Rurio, Professor Joseph, Professor Knowles, and all other professors, experts, and audience, I'm honored and delighted alike to have been invited as chair for this webinar section. Firstly, I would like to thank Professor Rurio and Professor Jess for their excellent keynotes on venous active medication. Being particularly interested in venous active drugs, I'm sure that their fantastic presentations on the controversial subject will pass on cutting-edge knowledge with genuine enjoyment. Unfortunately, due to multiple unavoidable time constraints, I will be absent during the webinar and will not be able to talk for long. However, I would like to take this opportunity to briefly introduce the therapeutic status and the medical position of venous active drugs in China. Numerous Chinese chronic venous diseases treatment guidelines have widely recommended venous active medications. Multiple conducted studies show that venoactive drugs such as ascorben-4, dusmine, melilotus extract, and other chemicals found in natural plants reduce edema, pain, or lower limb fatigue. However, I believe that further research can effectively extend the use and effectiveness, application, and mechanical understanding of venoactive drugs. I would like to invite Professor Jingsheng Wang, General Secretary, Chinese Association of Phlebotomy, to continue commentary on this topic on my behalf. Enjoy the webinar. Thank you very much.
And so we thank Professor Shenming Wang, and we welcome Professor Jingsheng Wang, a dear friend of ours who has been with us already, to give us the real final take-home messages. Jingsheng?
Thank you, Sergio. It's a wonderful meeting. And congratulations on Dr. Lori and Dr. Raspado's excellent talk about the venoactive medicine. And Dr. Lori gave the rationale of a venoactive drug in a CVD, and Joseph gave the mechanism. And actually in China, venoactive medicine used very widely. But I noticed like some patients react well to the venoactive drug, while some not. And actually in my practice, I found combination of different venoactive drug, like I combine sulu oxide and MPFF, and the patient feel better than one single venoactive drug. I know like Joseph pointed like how long, how tolerate side effect, but it is effective. Than, I mean, combined is more in the clinical patient response better than single. We need study more on this mechanism. And I also want to comment like, I mean, venoactive medicine, I mean, how big influence like between different managements like venoactive medicine and compression. I mean, that might cause, I mean, different, the patient's weightings and how guide our physicians to give their optimal management to the CVD patients. Thank you.
Thank you so much, Jingsheng. It's exactly 5:30 Italian time, so it's time to close, and it's time to recognize the wonderful teamwork of Professor Bottini and Professor Chi, together with all the other colleagues and friends involved in this project. So I will pass the mic to Oscar. Oscar?
Sorry. Nothing more to say, Sergio, only remind the importance of venous active drugs together with compression in the treatment of venous disease. Once more, thank you all for attending the 2 extraordinary webinars this weekend. Until next Sunday. Thank you.
Thank you so much, Oscar. Congratulations for the wonderful performance yesterday. And then Willie?
Great lecture from great friends, Professor Lurie and Professor Raffetto. Good morning, good afternoon, good evening. And see you all next week.
Thank you so much for short comments and huge work. At the same time, I'd like to close simply reminding the importance of venous active drugs and compression, but when validated and when based on science. You know, we are all for fake news-free communication. So I think, and I hope that this webinar was allowing us to be based on the evidence-based data. I deeply thank once again all the ones involved in this initiative. As we usually say in life, it's not just where you go, but also who you are traveling with. So we have already mentioned to you that next Sunday we will steer the boat and we will stay home virtually, meaning that Food for Veins will leave the floor to Venous Symposium. Professor Nikos Stavropoulos and Professor Tony Gasparis are dear friends and organizing an outstanding meeting that everybody should enjoy. So we will leave the room to that, and we will move the lymphatic module that was supposed to be on August 2nd to August 30. So we deeply thank all the ones who have been so patient to stay with us both yesterday during the Road to the Winter Dubai webinar, and to the ones of today, Food for Veins. We look forward for the upcoming week for the answers of our Mozart and Giuseppe Verdi. So our Professor Fedor Luria and Joe Raffetto for the truly outstanding webinar, and for the questions they will answer to in a written form in the website. We will go back to Food for Veins on August 9, so in 2 Sundays from now, with the module dedicated to pelvic venous disorder, always with an outstanding faculty. I would really like to deeply thank all the ones involved in this global group effort. And once again, I deeply thank you for your time and effort on this global initiative. Thank you so much, and have a great Sunday and a great week. Ciao. Bye.
Thank you, my friend. Bye-bye.
Thank you. Bye.
Gracias, ciao.
Bye.